So for all the young students, I would just like to say that you must follow the rules of the game. You can take shortcuts, but they won't necessarily lead to success. And you will find that one fine day you will land up in problem. And that is what surgery is all about. Following the rules, following the principles, and that is what will help you in avoiding all forms of complications. And the biggest challenge is if you operate at a wrong level these days. Many other things can be pardoned in the court of law, but if you operate at the wrong level while you had the facility for using fluoroscopy, there is no way, absolutely no way out. And therefore, you must always use a fluoroscope, identify the level clearly, do it yourself, don't rely on residents before they start, and always when you are operating, intraoperatively also confirm. And this is how you approach the cervical disc. I will skip all this part because it has been very beautifully covered by Kushan and also by Borkar for lateral masses. So I'll just talk about little bit about skin incision. A lot of people believe in giving longitudinal incision. Some believe in giving horizontal incision. The fact of the matter is that the healing for the horizontal incision is better. But at the same time, if you are operating for more than 4 levels or 3 levels, and if you are not comfortable, then it's better to give a longitudinal incision, as you can close that also. And ultimately, the bottom line is that during surgery, you shouldn't be having any problem. Then many of the people in the orthopedic groups and many neurosurgeons I have also observed, they believe in giving subcutaneous sutures instead of interrupted sutures. Again, the fact is that you want to achieve good cosmesis, and you want to whether achieve good cosmesis on table, or is it that the post-operative phase a person should have good cosmesis. So if you are giving interrupted sutures, the chances of having a better scar are more. And that's what has been proven many times by the plastic surgeons. Because if you are using a vicral suture in the subcutaneous plane, it also leads to scarring and it gives an ugly scar, though it looks better when you are doing it on table. The importance of correct plane cannot be overemphasized, and I will again not go into it. I'll just show you the video and there it will be clearer. Because if you lose the plane, you will end up either landing on the vessels or you will end up on the esophagus, and both these things are extremely important. And like it has been previously explained also, in case of a problem where you have hit a vessel, whether it's a vein, internal jugular vein, or it's a carotid artery, or some artery which was there, if you have hit it, it's important to keep your calm, use vascular clamps, and call for help. Because trust me, if it is bleeding profusely, it is very difficult for the primary surgeon until unless you are extremely experienced to suture that. It will be very difficult. So just keep your calm, apply some pressure, get suction, get light, call for blood, and then call somebody who is experienced in that field to do it. Now, like Khandelwal had shown you, that esophageal injury is what you have to avoid. And the tip for avoiding esophageal injury is good dissection. Apart from good dissection, you must know that some of the tools that you are using, they have the potential of causing injury. For example, the tip of the cautery. If you can see here, the tip of the cautery is like this. What you have to do is you have to cover the tip of your cautery and also cover the tip of your suction so that the current is not passed on to the esophagus. I've put this image for a very purpose, because look here, that there is a bare part which is between the cautery blade and the part which is covered by the blue sheath which is there. This part is bare, and from this part only at times current leaks and injures the esophagus. So this whole thing has to be covered completely, and this can be covered by a very cheap substitute like feeding tube or a suction catheter which is readily available in the operation theater, and you can use it to cover this. And then another important part is, apart from good dissection, you need to know how you have to place your retractors. Every retractor system that is presently being utilized by people, you can see has usually got 3 kinds of blades. One is this kind of a blade which has more tooth, sharper teeth, and one which is smaller, and one which is without. So these are the kinds of blades which you are supposed to place towards the carotid side into the longus colli, so that they take some the part of the teeth goes inside the longus colli and helps you retract it. While this part, which is blunt, this has to go below the longus colli, and this is the part which you have to utilize towards the esophagus. And dysphagia, again, Khandelwal has discussed in detail, so I will not go into the details of it. Good surgery, minimal amount of retraction will avoid all these kinds of complications. And I will not talk much on this because it has already been covered. Similarly, recurrent laryngeal nerve palsy has been covered by Khandelwal. And just to emphasize that in my practice, in my personal experience, I have rarely seen recurrent laryngeal nerve palsy in anybody. Because if you will respect the planes, your retractors are below the longus colli, you will never see it. People talk about going from the left side, going from the right side, the importance of being on the left side. All neurosurgeons in my department operate from the right side only. And because most of us are right-handed, it's easier for us. But despite saying this, I have yet to see a real case of recurrent laryngeal nerve palsy in last at least 5 years. Okay, so if you maintain the planes, it will be hard to injure like a recurrent laryngeal nerve. But if you don't maintain the plane, it's very easy. And yes, dissection is the key. And similarly, injury to the sympathetic trunk. If you dissect the longus colli too laterally, you will hit the horner, you will hit the sympathetic trunk, and then you will have this kind of a complication. There are many people who do minimally invasive endoscopic discectomy and talk about it. The most dreaded complication that I think that minimally invasive discectomy has is this only. Because your docking is on the lateral aspect, you cut the longus colli on the lateral aspect, and whenever the heat is transferred to the sympathetic nerve, you are likely to have, your patient is likely to have this Horner syndrome, which can be very easily avoided. Bhavak took a very nice talk about profuse bleeding and how to stop it. Profuse bleeding in anterior cervical discectomy usually happens from these veins which are on the lateral aspect or on the lateral aspect, and also from the vertebral artery if you go terribly wrong beyond the oncovertebral joint. And that also occurs in less than 0.3 to 0.5% of cases, and that too occurs in inexperienced hand. In an experienced hand, you will get to know where the oncovertebral joint is. So see, if you are young, you should see and how this experienced surgeon is operating. You should ask question where the oncovertebral joint is. And when you are assisting, try to feel for it with a number 1 forceps so that when you are operating on your own, you know where to stop. And that's the most important thing. And coming to the neural injuries, many times people are using very high-speed drills and they don't know how to hold it. If you don't know how to hold this kind of an instrument, it's a problem. So, and if you are holding it too tightly, it is difficult. If you are holding it too lightly, again, it is a problem. You should hold it like you hold your pen, and you should wield it like you wield your pen. And you should be as accurate like you are writing. And it is only then you will be able to avoid any form of injury. Before you go in, you should press the pedal and see whether your drill is working fine or not. And when you are going to drill inside, you should ask your assistant to protect all the important structures which are around you. Moreover, if there is any cotton which is there in the field, you should remove that cotton, because this high-speed drill creates a negative suction around itself and will pull the cotton or the threads which are around, and that can also lead to injury. So you should remove everything from the field. In case of dural tear, you should not worry. Most of the dural tears can be easily repaired using Duragen or glue with the help of CAT. This is what we do in the anterior surgery. But in case you are able to repair it, there is nothing like using a Prolene 70 or 80 and repairing it primarily, and over which you can put the glue. But usually in most of the anterior cases, even if there is a leak, usually you can get away with it by using the above methods. And regarding the post-operative hematoma, I must say that good surgical skills, again, are the key to avoiding this kind of complication. At the end of surgery, you should inspect that there are no bleeders. And while you are dissecting through the planes, if you are in the proper plane, you will rarely encounter any vessel, which you are very, very unlikely to happen that you will encounter any vessel. And if there is a big vessel, it's better to tie it and then cut it rather than just coagulate and cut it, because after some time, the vessel can bleed again. Cage subsidence, again, Khandelwal had covered very well. So I will just briefly say that your end plate preparation should be very good. And the cage should not be over distracting. The modulus of elasticity for the cage should be such that it meets the density of the bone. In case you feel that the bone is osteoporotic, it is better to put in the autologous bone of the patient rather than putting in a titanium cage or even a PEEK cage. PEEK cage is better in my opinion in comparison to titanium cages, because its modulus of elasticity matches more the normal consistency of the bone. And discectomy and end plate preparation, usually you can use very simple instruments like these and curettes, and you can prepare them. Cervical screw pull out, again, the important point to remember is that your screws should be divergent, and straight screws, whenever they are put, the chances of pull out are higher. So putting in divergent screws above and below, and at the same time convergent screws on the same level will help you achieve better screw pull out strength. And I will leave this, and I'll just skip to the video, and I'll just play the video for your sake. So see, you don't require many instruments. You require just one retractor. I'll just hold on for a second here and go back. So once you have given the incision, use your finger and develop a plane between the sternocleidomastoid and the esophagus. Once you have developed the plane, with the index finger, you should try feeling for the bone which is below. And once you have reached that, try using a sharp dissection till you reach the longus coli. And once you have reached the longus coli, you can use this kind of a peanut to improve the plane and the space, like this. And then again, see what I'm doing. This is the cranial end, this is the caudal end, this is the esophagus, and this is the lateral aspect. I am putting the retractor. I am putting the retractor, which is blunt, toward the esophagus side, and this is the retractor with the tooth, which I am putting towards the carotid side. And see how I am using the cautery. And then again, Khandelwal had shown you that he bends the needle like this in a Z-shaped manner. And the purpose of bending this needle is that you cannot enter beyond a certain point, and by mistake, you will not injure the cord. And this needle will obviously will stop at this Z point. So we do like this. And then we take an X-ray and confirm the level. And then using disc curettes, you can take out the disc with the help of the drill. You can drill out the osteophytes which are there in this region. And always you should support. If you can see here, one of my fingers is supporting the instrument which I am holding in my right hand, and I am holding the instrument with the palm of my right hand, and my left hand's finger is supporting it. The purpose is to develop bit of more accuracy, at the same time provide support. And if you look at the movement which I am doing, the movement is circular. At the same time, I am always trying to come out from within. I'm not trying to push anything inside. If you try pushing anything inside, then there is a chance of causing injury. Here, if you can see, what I'm doing is I'm putting in a vertebral body retractor. Different kinds of vertebral body retractors are available in different setups. This is the one which we have in neurosurgery. There are company people who have vertebral body retractors, which are with pins, and they are also really good. You should not retract much so that you don't cause adjacent segment injury. It's better to just have an optimal degree of retraction so that you can see clearly where the posterior longitudinal ligament is. And then using micro forceps, you can cut it. And we in neurosurgery always cut the posterior longitudinal ligament and try visualizing the dura below. Once the dura is visualized, we put in a this right angle dissector, very small dissector inside, and try feeling for the dura or see there are no compression anywhere. So see how I'm putting it below the PLF. Once I've done that, I will put a blade and I will cut it on the lateral aspect, and then using upcut, I will remove all of the PLF. Okay. And there are few osteophytes at the bottom, which I am trying to drill off and create some more space. So now you can see that dura is clearly visible at the back, but still there is some amount of ligament which is there, which I am trying to remove. And I will just put in the cage here. And this patient also had a fracture. So we removed that small bit of fracture and then hammered the cage inside. And then we have put in a plate. And Dr. Kamran wanted me to show some video. So this is one more video. I think this is for corpectomy. So same steps again. Once you have bared the vertebra, you take out the disc below and create some space here by taking out the disc below. And we ask our assistant to protect the esophagus so that by mistake our curette or our blade doesn't injure the esophagus. Like you see here, I am protecting the esophagus. So once this disc is taken out, I'll just fast forward. We go to the next level and we take out the disc there also. So I'm taking out the disc at the next level above, and this provides us some space where you can use your other instruments and harvest the bone as well. And then we take out the bone which is present in between, do the corpectomy. And once adequate space has been created, you take a cage, measure it well. And once the cage is of appropriate size, you fill it with the bone that you have harvested. And then filled with the bone, you can put in a cage there. And again, in the same manner, plating can be done. You must ensure that the edges of the cage are below the bone, above and below also, superior and inferior aspect below also. And then you put in the screws. Coming to the lateral mass screw fixation, Sachin has covered everything, and I will not go into the details of Roy Camille technique. I'll just emphasize the same thing that Sachin had said. And I'll skip all this, I'll skip all this, I'll skip all this. So we use more often than not, I don't remember when was the last time that we were using fluoroscopy for putting in all the lateral mass screws. You can avoid that and use the technique that Sachin had told you. The easiest way to memorize that technique is remember 2020. So he showed you this image. It's a modified Medved's technique that he had showed you, where the entry point is taken 1 millimeter below. So what is the 2020 technique? Just remember, instead of 1 mm, you can very easily remember 2 mm. going 2 mm inferior. So it will not make a big difference, but it makes your life easier because it helps you memorize things. So you can go 2 mm inferior and 2 mm medial from here to here. So 2 mm inferior, 2 mm medial. But the caveat is, to avoid any complication, you must expose whole of the lateral mass. You should be able to see this rectangle here like this on table. And it is only then you will be able to identify the central part of it. And then you go 2 millimeter inferior and 2 millimeter medial. And then how do you angle? You angle 20 millimeters, 20 degrees up. So what will happen is when you are angling 20 degrees up, if you remember the video that was shown by Sachin, your screwdriver or the awl that you are using for creating the hole will be touching the inferior part, inferior spinous process. Here it's seen that you are touching the same side spinous process, but it will not happen. If you are angling it 20 degrees up sagittally, it will be touching the inferior spinous process on the lateral aspect. Okay. And you also have to direct the screw 20 degrees outward. If you are directing 20 degrees outward, you will not hit the vertebral artery. At the most, you will come out here. At the most, you will come out here. But your vertebral artery will be safe. So this technique, I call it 20-20-20. This is how Professor Kale taught me. And we have been practicing it since ages altogether without any complication. 2 millimeters inferior, 2 millimeters medial, 20 degrees up and 20 degrees lateral. That is all. The another point which I would like to emphasize is when you are using the awl, like all these things that I have said here are correct, except one thing, that the starting point, when you are using the awl, you should be placing it perpendicular so that if you don't slip out of this entry point, because if you are angling like this, you may end up slipping out. So create a very small hole first here so that your instrument doesn't slip off. So once you have created a very small 2-3 millimeter hole, then you can start angling things inside. But if you start it from the very beginning, your instrument will slide off, you will injure the muscles which are present on the lateral aspect. And yes, there can be multiple complications, fracture of lateral mass. So how to avoid fracture of lateral mass? The trick is you rotate the screw, say 1.5 circles, and then you stop. Take a breath, talk to your colleagues there, and then again rotate it. So very slow screw insertion. If you are trying to be fast, there are chances that in small lateral masses, especially in children or osteoporotic bones, you might end up fracturing them. And another important point is the correct entry point. If your entry point is lateral, the lateral mass is very small, you will end up damaging it. Similarly, vertebral artery injury will happen only if your trajectory is not right. Okay? So you have to be very careful about it. Rest of the things, I believe Sachin has already covered and I will not talk about it. And I will also skip this because I believe it has been covered. So to conclude, follow good surgical technique. Sharp dissection should be done in case of ACDF till the time you reach the vertebral body. And then only with minimal amount of cautery, you can separate the longus colli from the midline. Try separating only as much as it is required. When you start seeing the curvature of the body, that should be the end point, and you should not go beyond it because you will hit the sympathetic nerve. And you should go to step 2 in spine surgery once the step 1 has been completed. So if there is some amount of bleeding, blood is coming in your field, or if there is some problem with the retractor, do not go to the next step. See what is the problem, sort it out, and then only go to the next step. And I hope if you follow these principles, you will never land up in trouble. Thank you.